Now, you're going to have to forgive me because as going through, there might be a bit of a delay. So if I start speaking ahead of my slides, I apologize. But thanks for the chance to chat with you today. My name is Kirk St.Amant, and I work for the Center for Health and Medical Communication at Louisiana Tech University. And one of the things that we sort of focus on is developing usable healthcare products, be they written documentation, online informational materials, down to interfaces for different technologies that help patients interact with healthcare systems in effective ways, or they can use information or technologies to maintain or restore their own health. And what I'd like to discuss today is sort of a bit of an approach that we use to engage in usability within the healthcare context. And specifically, what we try to do is we try to focus on the aspect of cognition, or how the brain processes information and what those mental activities mean for our expectations of usability, what we expect to be used, how we expect it to be used, and what we expect to do or how we expect to act and behave in response to different contexts. And to sort of look at that relationship between cognition and behavior, or cognition and expectation, I like to throw out just some basic medical concepts. So, for example, if I say the words blood pressure, or you hear the words blood pressure, your mind begins to access certain mental representations of things. And if I push it much further to say be a specific process, like check blood pressure, your mind begins to act in some very specific ways. In fact, the moment you encounter that expression, one of the first things your mind does is access a mental model, a representation of the space in which, or the location at, that process should occur. Or based upon your experiences over time, you know that whenever you encounter this expression, check blood pressure, your mind accesses this space, this representation of it. You know what is in that location, how things are configured, what even things might sound or smell like. You know the location automatically upon what your brain draws up when it encounters that term. But that knowledge of expectations goes more to just space. It goes into deeper detail in terms of in that location, you know exactly what will be used to perform that process. It's not a surprise. You sort of know what will happen. You know how it will be designed, what it will feel like, what it will look like, what it will sound like when used. You also know who will use that particular technology on you in that location to perform the process, and you know the nuances of what that activity will entail. You know what to expect in advance before anything happens. You know how to behave, how others will behave, what will be used, and how they will be used simply by the way your brain accesses certain information based upon the input it gets from words or from language. That whole sort of expectation cycle, or that whole thing that your brain does, is multimodal. It's the sounds, the sights, the smells, the taste, the feeling sensation that is all wrapped up in that particular activity. It all comes up at once, to the point where you know what a blood pressure cuff feels like before it goes on. You know what it will sound like as it's inflating and deflating. You'll also behave in turn. You might even start to roll up your sleeve before the process begins. You'll reflexively extend an arm to receive the cuff, and so on and so forth. This reflexive behavior that happens the moment your mind encounters something and knows how to behave, we're going to call that a cognitive script. Or cognitive psychologists will refer to this as a script. It's kind of the mental model that our brains automatically call up and guide our behavior, so that it happens reflexively in a location once we know what's going to happen. That is, once I give you a common process, your experiences engaging in that process in a setting establish where you expect it to happen, what will happen, how, and so forth moving forward. Now, where those scripts are kind of interesting when it comes to healthcare is, traditionally, most healthcare has occurred in a specific healthcare providing location. Certain particular spaces that were, say, official healthcare spaces, where certain trained healthcare professionals use certain technologies to perform processes on you as a patient. And in that context, usability took a rather interesting design. It was, in many cases, passive usability, or if you will, indirect usability. That is, someone else used a technology on you, or someone else performed a process on you that sought to monitor your health or to restore your health in some way. Within this interesting context, you were sort of the patient in the loop. Things were being performed on you that affected you, but you weren't actually performing those things. Or technologies were used, but they were being used on you versus you using them yourself. And within sort of that kind of framework with usability, success was based often on patient comprehension. Does the patient understand what's going to be performed on them? Do they understand who will perform it, what that person will do, what will be used? But it was very much passive activity. The behavior we expected to engage in was to sit and have things performed on us versus actively do things ourselves. And so within that framework, quite often health literacy arose, if you will, in relation to comprehension. Do you understand what's about to happen, what will be used, what someone else will do on you? And so that often guided health usability or how we thought about it traditionally. But in recent years, we've seen that dynamic change quite markedly. And that is increasingly the amount of time we get to spend in direct contact with professional healthcare providers, physicians, nurses, PAs, and so forth has decreased markedly. Also, the amount of time that we get to spend in a hospital or a medical treatment facility to have our health monitored or treated has also declined. We're increasingly seeing patients being asked to engage in more and more of their own health monitoring, health maintenance, and health restoration activities outside of healthcare contexts and on their own. And as a result, we've seen sort of the dynamics of health usability and health literacy shift in response to that. And what's interesting is as more and more individuals have to engage in their own healthcare, we've seen a range of different technologies emerge to try to meet that new market or meet that new need, to try to help individuals monitor their health, to provide individuals with information or technologies that help them restore and maintain their health. We've also seen entire healthcare service sectors emerge designed to help patients treat themselves or help us treat other family members outside of, say, quote unquote, formal medical contexts and without the presence of trained healthcare providers. It's gotten to the extent that we now see entire informational services have emerged to try to help us engage in these activities in more informed ways. So within this context, by moving healthcare outside of more traditional healthcare settings, we've shifted usability from a passive activity to a more active one. And that is its direct usability. We are the users of the technologies that are used to monitor our health, to maintain our health, to restore our health. And with that direct usability, we are performing processes on ourselves and watching how we react to those processes and those uses. So it's no longer patient in the loop, it's rather patient is the loop. We are the feedback mechanism of our own actions within this context. And as a result, this shift in usability has changed in terms of how we think about it. It's now no longer a matter of just understanding, but it's understanding these dynamics of scripts or behaviors, how our mind thinks about these processes, what it needs to know to engage in them effectively, so we can use materials, be it information or technologies effectively to engage in our own healthcare practices. What I'm talking about is something that Lisa Melanson of Clemson University calls patient experience design. It's the idea that health literacy needs to evolve so that usability is central to all that patients do as patients are increasingly engaging in their own healthcare. So information needs to be written for them as a primary audience. Technologies need to be designed so they can use it as a primary user. And so what I'd like to talk with y'all about today is approaches that can help engage in that activity to design effective materials for different users or different patient groups. The process I'd like to discuss is called script mapping, or these cognitive scripts that guide our healthcare behavior traditionally. How do they work? How do we create them? How do we tie onto them to create usable products, be it an instructional text or the interface for a monitor? And so mapping scripts or uncovering these dynamics often follows a certain process. And as I mentioned earlier, that process often begins or is connected with a model associated with a specific location. Within usability, often we call this context of use. What's the setting in which something is used because the parameters of that setting dictate the constraints and affordances of use in that location. Here we'll call it context of care because it's what setting will this healthcare activity take place in and how do the constraints and affordances of that location or setting affect what individuals can do in terms of maintaining, monitoring, treating their own healthcare conditions. So as I mentioned before, location tends to drive everything. The mental models or scripts we have for performing healthcare processes traditionally are all linked to places where they happen. Once the model of place emerges, what is used, how it's used, who uses it, kind of falls out of it naturally. One set of expectations builds into it another. And so the where part, or where things happen, becomes incredibly important with healthcare usability. Because once you know the where, again, your mind needs to fill in blanks for who will perform the process, what will they use, and how will they use it. And it turns out that our minds are kind of designed to build these scripts for behaviors, particularly standard behaviors, quite quickly and readily. But we need to fill in certain slots, and those slots are quite often the location where something happens, and then who is performing the process in that location, what are they using for that process, and how do they use it. So anytime we try to build something for the scripts people need to develop, we need to address those factors. As I mentioned before, what's changing now with healthcare is the context in which healthcare is actually being done. And it's more often our own lives, our own homes. And so if we shift the check blood pressure from a medical examining room in a hospital to the kitchen in our own home, that changes all the other parameters of location, including who performs the process. It's no longer a physician, it's usually us. What's being used. It's quite often not the manual sphygmomanometers that are used in hospitals, but more sort of digital blood pressure cuffs we can wear akin to a digital watch on our wrist. And the process of checking your blood pressure becomes almost automated through the device versus someone manually sort of observing or checking the pressure that occurs in a specific physical gauge as it goes up and down, releasing the airflow to release pressure accordingly. It's now become more digitized. And so different sort of elements of this script or set of behavioral expectations falls out of this different location. But what's become sort of an overlooked factor in all of this when it comes to health usability is the concept of when. And that is, before we start talking about the location where something is done, we need to ask the patient we're designing for, or the person whose experience we wish to map, when they are performing a certain process in that location. And here's the rationale behind it. If I tell you I check my blood pressure in my kitchen, that might lead you to assume certain conditions are present, and you try to design for those conditions. But if you ask me, well, when do you do it? And I respond by, well, I do it very first thing in the morning before I have breakfast. I'm up at 5 o'clock, no one else is around, it's completely quiet, there are no distractions. At that time in that location, you know that you have my full attention, and you know that you have essentially my full working memory, my full short-term memory. So if I need you to remember certain things over the course of a few moments, you have that free mental space to do so. And I have your continual attention to perform a process versus it jumping back and forth and I need to acquire it. So I can essentially assume that you can engage in a rather smooth and even process from beginning to end. So I designed something that works for that smooth and even process in that space due to limited distraction and full sort of focus on a particular topic. If, however, I shift that to say, well, I check my blood pressure in my kitchen after I pick up my grandchildren and go home, and I'm cooking dinner for them while I'm watching them at the same time, that's a very different set of parameters in that same location based on time. Now my attention is scattered and it's short. My working or short-term memory is completely divided between what I'm trying to do in terms of cooking, as well as watching children, as well as checking my blood pressure. All of those factors mean the design of something must be completely different because my attention and memory are completely different, and my shifting back and forth during a process is no longer smooth. It's going to be broken and uneven. So that when dynamic often becomes key. So it's asking, when will our patient engage in this process, use this thing, be it a text or technology? And then where are they at that time? What are they doing in that place at that time to try to gauge their attention, their short-term memory, their focus, how much they'll be able to complete from time to time or task to task. I also need to know who is there. It's just me checking my blood pressure by myself. It's me and my adult daughter. It's me and my adult daughter and my grandchildren. Once I know who is in that space, I want to follow up and ask, what are they doing there? Well, my adult daughter is talking to me as I check my blood pressure, and both of us watch my grandchildren. So automatically, I know that the individuals in that space are distractions and that they're taxing your short-term memory as well as your attention, so I need to design accordingly. If, however, I flip that and say, well, my daughter is there because she is actually performing the process of checking my blood pressure while my grandchildren sit quietly in a corner and draw, that's a different dynamic. That means that I need to design differently for someone else who's performing a process with me. I then need to figure out what is being used. And again, the challenge becomes, just because you were used to using a specific technology in your home to do something doesn't mean I'm using the same technology. So I need to figure out, what are you accustomed to using? What are your expectations for that item? So I correctly address them if I try to design instructional text or say even visual interfaces for you to use to engage with that product. How, based on your experiences, do you think this should be used? Or have you used this in the past? So if I provide you with something, it's something you're familiar with and can use again successfully and effectively in that setting to engage in care based upon the affordances or the constraints that are limiting your attention and your memory. And a key final part that often gets left out is kind of this final what. After you've completed this process of checking your blood pressure, what do you do next? Well, I call my doctor and let him or her know what the results of my blood pressure test were. Well, if you're doing that, then if it's the interface on a device, that interface needs to remain displaying until you finish the call with your doctor so you can read those numbers off. Or maybe you need to take a screenshot of it and email that screenshot to your doctor so she or he can review it as you're on the phone with them. Those parameters greatly affect how you design the technology to be usable in that space. Maybe I need to write down and record manually in a journal what I noted for those numbers. Again, in that case, how long must the display remain active before it shuts down or goes to sleep, or I've got to touch it to reactivate it so that I can copy those numbers down? Versus say I check my blood pressure, then I put away the blood pressure cuff and leave for the day. That's a very different set of expectations around behaviors that affect what kinds of designs are workable or usable or not in that setting. So when it comes to sort of addressing these script factors, we try to collect information about them to determine what scripts affect individuals' usability expectations and the cognitive script processes they have for engaging in healthcare and using healthcare materials. And to do this mapping with the center that I work with, we use sort of a 5-part process, or if you will, a 5-question set process that tries to mimic what I just talked about with scripts in terms of expectations. And so the first set of questions gets at the kind of when, where, the basic dynamics of location, what's in that location, how the constraints of that location affect your attention and working memory. When do you perform this process? When do you check your blood pressure? When do you check your insulin? When do you take your insulin? Where do you engage in that process? Can you describe that location for me so that I don't assume your kitchen is configured like mine just because you said that you do it in your kitchen? That your kitchen is the same light flow as mine, same airflow, same internet access as mine. So I don't make mistakes in terms of how I design something for you to use. And then what are you doing at that time in terms of, again, your distractibility versus your focus? The second sort of cluster of questions gets at the who, what. Who is in that location at that time and what are they doing? Are they contributing to this process and I need to account for them? So I create materials both of you can use in tandem? Or are they a potential distractor? So I know your attention is constantly shifting and I need to design an interface or body of text that lets you shift attention quickly and effectively. Back to then, who is performing this process and how are they doing it? What are they using to engage with the process? Can you describe the process for me so I can correctly understand your expectations, whether fully formed or partially formed, to try to create something you can easily recognize, understand, and use in that setting? And then down to sort of the fourth set of questions, well, how do you or does that other person perform this process? Describe what is done accordingly as best as you can. And again, the idea is to get at what are your expectations based on your experiences. If you have none, how much information do I need to provide to sort of fill that gap and let you understand what's about to be done or how to perform certain activities? Right down to sort of the final question set, which is after the fact, the what, who. After the fact, what do you need to do and who do you need to interact with to say share information, to record information, to know how to do the final phases of that design so you can still use the technology if needed after the actual process is performed. And the idea is using these sort of question sets to ask questions of the intended user group or the intended patient group, or it could be multiple groups of patients that we need to build something for, design for, share information with, to figure out what are actually the scripts that they work with in their daily lives. What's the context of care they're engaging with, and how do we need to create usable products for them in that context? And collecting that information from these individuals is a matter of individual interviews in which we ask these questions to members of that group, as well as focus groups, where we ask these same questions to groups of 3 to say 8 members of that same group. The idea being we can get very rich data from individual interviews, but we can also get more complete data, if you will, from focus groups where if someone forgot something as they responded, someone else can fill in that gap. And by using the results of interviews and focus groups according to these questions, we can try to design healthcare products that individuals can easily recognize, understand, use, and make sure they use effectively and successfully in the context where they would perform that process. So they can be comfortable being that the loop itself that is engaged in this activity. Once we've unpacked or uncovered these different dynamics of script around these 5 questions, we then have to apply them or determine how we can use this information to design effective or useful products. And sort of the structure we've come up with addressing it or applying that data to usable design in healthcare contexts is something we call AFCOS, or the AFCOS approach. And it looks at 5 key variables of usability in a context whenever someone is engaged in healthcare. Once we know the data of scripts, how can we engage it to create interfaces or texts that are easily usable in that setting? And so the A part stands for accessibility, or how are individuals accessing the information they need or accessing the materials they need to perform this process. And this is kind of the brute force. Are they using digital text or written text? Am I designing a website for someone to perform this process? Is it an app or something they're going to look at on their mobile phone? If it's a mobile phone, I'm going to design the screen differently than if it's a website they look at on their laptop. If they're preferring to get something in print documentation, am I mailing it to them so they get the exact thing that I provided for them? Are they downloading it from a website? If they're downloading it, are they printing it out? And if they're printing it out, do they have access to a full color printer? If not, how do I need to redesign the text I'm providing so they can use it if they only can view it in black and white? But it's more than just information, it's also the technologies and materials being used. If I'm getting a blood pressure cuff to check my blood pressure, did I get it from the hospital? Did I get it from the dispensary that's at the hospital? Do I know what models and makes of design device that I'm using? Am I getting it from my local department store? If I am getting it from a department store, what maker models are available to me there, akin to if I'm getting it online? If I'm purchasing the product online to use for myself, what am I actually using? So I know the different nuances of how access factors affect what I'll actually be using to engage in healthcare and can design accordingly. There within, it's also, am I accessing this by myself? Am I reading information by myself? If so, pages need to be configured a certain way, as do websites. Am I reviewing something in tandem with someone else, like a healthcare provider? If in tandem, the orientation of that page needs to be different. And it needs to be different if someone is reading it to me upside down and backwards while I'm, say, holding a brochure and reviewing it as it's being read to me. So all small details of access, but do affect the usability in that context based upon what we've discussed. Next is findability. Can individuals find what they need to engage in a healthcare process effectively? In the case of written text, are they not a matter of not overwhelming them so they've got to sift through massive amounts of text, but knowing that their attention will shift rapidly back and forth and organizing things into manageable chunks, bulleted lists, numbered headings, highlighting certain passages so individuals can easily relocate their place as they're going through. It's also a matter of knowing that certain technologies we think we can reflexively use because we've used them so often, we use them without thinking. But when we pop a new technology in there that we're not familiar with, we need to explain to individuals what it is and how it works so that they can build out this script understanding of how different parts and pieces fit into an overall model of providing healthcare in a setting. It also comes down to choice and not overwhelming somebody. If I'm doing something for the first time, I don't want to provide someone with too many options or too many sensory stimuli that will overwhelm them. But I want to try to make things easy to find by limiting the amount of choices people have. So each step limit the number of choices and help guide the choice by explaining what's to be done, helping them find the pieces and parts, buttons and features they need to use at each step of a process. From there, we go to comprehensibility or understanding, akin to basic health literacy concepts. Do you understand the information being presented? Is it in technical healthcare terminology that we need to re-render in everyday language for the patient to understand? Is it taking long, complex sentences that require intense focus and an understanding of medical jargon and shifting them into quick checklists that individuals can easily read, understand, and act upon in that setting when they're trying to do other things? It's also a matter of not overwhelming somebody. Just because they can understand all the choices on the interface doesn't mean we should overwhelm them with options at one time, but rather should keep things simple and easy and understandable and recognizable based on prior experiences so they can understand what they're engaged in as they perform a process. Built within that is the concept of operability, and that's simply because I understand what you're telling me to do doesn't mean I can do it. I can read and understand instructions on how to perform open heart surgery. That doesn't mean I'm able to do it. And it's the same process. Simply just because individuals understand how to use an app that I provided for them, if they don't have Wi-Fi in their location, they can't use that app effectively or successfully. Likewise, if I'm requiring them to use power to plug in a technology, but they don't have a power source or an outlet in their kitchen where they're performing it, or they have a regular haphazard power in their location, then thinking of a different configuration, battery powered, solar powered, might be different. Likewise, what's the lighting like? If it's in a low light environment, do I need to create a screen that automatically adjusts its luminosity so individuals can read it in low light environments? Do I need to design text with large print so people can easily read that text in a low light situation? Right down to, do I know what devices people expect to be able to use so I give them what they're familiar with and can operate, because their ability to operate and use something they've never seen before, even though they might be familiar with it, is limited. And if I require them to use it, they are going to have questions and there will be problems. To the final part, sustainability. How often do individuals need to perform this process in this space over time? And sustainability often comes down to, can I go back to the same point and use it again? Designing physical printed text with built-in bookmarks so individuals can go back and find a needed passage again. Helping individuals know how to bookmark websites if they've never done it before, but they need to use a website to perform a process, providing an instruction. Down to, if I'm giving them printed pages, also providing some sort of folder to contain them in and make it brightly colored so they can find it when they need to perform the process again. Or even making it a magnetic card they put on the refrigerator door for everyday health activities so they can easily locate, follow, and perform it. Back down to, if I'm going to have them do Wi-Fi access to do things, is it available every day or only certain times of day? If only certain times of day, I need to think about how I'm going to ask them to do things and configure materials so they have that access. If it relies on a third party to come in and perform a process to them, how often does that third party come in? The nurse visits once every week, therefore I need to scale how I'm going to do this project or how I'm going to have you do this activity to a weekly basis. Down to, if I need someone to explain things to me as I engage in a process, how often will I interact with that person? So I change the scale to address that accordingly. But essentially, it's kind of, how do you plug in the information we've collected on scripts based upon interviews and focus groups to make it usable and manageable in the context for individuals engaged in healthcare? Essentially, the mental models that we've had traditionally for healthcare and usability have focused on fixed spaces where professional healthcare providers engage with and use things. We're now shifting to a more external focus where patients themselves are central to the process and engaging in their own care. To create usable technologies, texts, or anything that relates to healthcare in such environments, we need to understand the patient's expectations, the patient's context, and what the patient expects to do and can do through their understanding and surveying, working with, and collecting data directly from them. Once we have that data, we can work it into sort of different kinds of formats to address what we know about script expectations and contexts, to design usable materials or usable text for individuals that they can allow them to engage in effective healthcare. Essentially, it's all about the patient being central to the design and usability of things, where they essentially are the loop through which activities play themselves out, things are used on and cause reactions within. And the more we can make patients central to how we engage in the usability process for healthcare design, the more successfully we can address healthcare moving forward. Thank you all for your time and attention this afternoon. I greatly appreciate it. And I'd be happy to take any questions now. I also have my email address listed there, and I'm happy to respond to any emails with questions you might have later. Thank you all very much for your time. Questions? I'm sorry, I couldn't hear. Could you come a little closer to the mic, please, or with someone
Thank
closer?
you also, by the way.
My pleasure. Again, if there are questions, please feel free to email me. And thank you so much for your time and attention today. I appreciate it.
I don't think there is any questions. Thank you so much for talking at UX Days
Thank
this
you.
year.
thank you for organizing this. Thank you for letting me do this by Zoom. And I appreciate all your patience and help with this. You have a great afternoon.
Yeah, thank you. You too.
Take care.